All right, so antibiotic review. This is going to be like a triple distilled antibiotic review. I basically took and went through all the antibiotics, and I pretty much just kept all of the bare necessities that you need to know for your boards, for your exams, and things like that. I'm not going to cover every single detail. I'm not going to cover every single antibiotic, but I'm going to go over the main ones, the ones that you really need to know for your exams, and the things that you need to really be familiar with. So let's go ahead and get started with that. I wanted to thank everybody for the support, the really nice comments, everything. As always, thank you so much for that. I appreciate that more than you know. So let's go ahead and get started with antibiotics. So we're going to first start with the beta-lactam. So that's penicillin, cephalosporins, carbapenems, monobactam. Makes sense to start with the OG antibiotic, and that's penicillins. There's a lot of different subtypes of penicillin. We basically had to evolve as bacteria became resistant. So I'll break down each individual one and kind of progress as we did in real time with the penicillin. So let's start with plain penicillin, the original. So we have penicillin G, penicillin V, or also known as penicillin VK. V is PO, so it's by mouth, and then penicillin G comes in both an IV and an IM, an intramuscular form. So what does penicillin cover? Well, it covers gram-positive really well. It has really good gram-positive coverage. But the problem is it's been around for so long that it doesn't cover a lot of things that much anymore. There's just been a lot of time for it to build resistance. A lot of the organisms are resistant against it now. But there's still a few things that it's really good at. So what is it still good at? What are the high yield indications that you need to know? Now, again, with these indications, I'm not going to list every single thing. That's ridiculous. You'd never be able to memorize them all. I'm going to focus on the main things, the things that always seem to come up on the board. So for penicillin G and penicillin V, that's going to be syphilis. That one's huge. If you don't remember any of the other ones, I'd remember that. Strep, pharyngitis, dental infections, rheumatic fever. Of course, rheumatic fever is caused by strep, so it makes sense that it would cover that. So those are your first lines for your penicillins. So first line for strep, that's why I said we also see it indicated for rheumatic fever. It can be used for dental infections. It does cover most of your oral anaerobes. But the high yield one, like I said, that's syphilis. That's the one they always ask you about on exams. That's when we use penicillin G, of course. So that's the injectable. And just an FYI, in regards to strep pharyngitis coverage, so in real life, when you're actually practicing and you're prescribing, while penicillin V is a first line for strep, it works well. You're really not going to prescribe it very often because in children specifically, amoxicillin is used much more often. It's more palatable. It tastes better. They have the bubblegum amoxicillin. Penicillin V does not taste good. And then the other thing is amoxicillin has twice daily dosing, where penicillin VK sometimes can be up to 4 times a day. So in real life, you're probably going to prescribe amoxicillin, but know on the boards, on the exams, that you may have to pick penicillin V for your strep treatment as your first line, but amoxicillin works just as well. All right, so let's progress on here. So penicillin was our first antibiotic, but eventually bacteria started to evolve and resisted penicillin by producing something called penicillinase. So we had to go back to the drawing board. We had to come up with a semi-synthetic penicillin, and that was called penicillinase resistant, also known as anti-staphylococcal penicillins. So what penicillinase is, it's an enzyme that's produced by the bacteria that basically destroys the beta-lactam ring of penicillin, which makes it ineffective. So the meds in this class are nafcillin, oxacillin, dicloxacillin. Back in the day, this list also included methicillin. It's how we came up with the name MRSA, methicillin-resistant Staph aureus. We don't use methicillin anymore. It just has a really poor side effect profile, and these meds work better. So methicillin is how we came up with MRSA. It's in this class, but we just don't use it anymore in practice. So what do your penicillinase-resistant penicillins work well at? Gram-positive. It's going to be your MSSA. Your high yield indication is going to be your methicillin-sensitive Staph aureus. So that's what you're going to use it for. So whether it's bacteremia, osteomyelitis, cellulitis, endocarditis, if it's from MSSA, these are generally going to be your drug of choice. These meds basically exist to treat staph. That's why we made them. That's what they're good at. It's the only indication I would know for them. Nafcillin, oxacillin, dicloxacillin, staph, MSSA. Does not cover MRSA. It's not good for MRSA, but it's good for your methicillin-sensitive Staph aureus. So when you think of your nafcillin, oxacillin, dicloxacillin, just think of staph coverage. That's all you should be focusing on for these drugs. That's why we made it, and that's what they're really good at. All right, so we created penicillin. We covered strep and staph. So most of our gram-positive organisms, but the last 2 generations we just talked about, they didn't really cover gram-negatives. They had very poor gram-negative coverage. So we had to come up with something that did. We had to create a penicillin that also covered our gram-negatives. So we developed what's known as aminopenicillins. You'll definitely recognize these. They were created for that specific reason, to fight gram-negative infection. So our aminopenicillins are going to be all the AM prefixes, amoxicillin, ampicillin. If you ever forget which one is oral, which one is parental, parental, of course, means non-oral route, IVIM. Remember, amoxicillin, the third letter is an O, which stands for oral, and ampicillin, the third letter is P, which stands for parental. So because your parental is your IVIM, your amoxicillin is your oral, just in case you forgot that. You probably already know that. Now, what do these cover? Like I said before, they cover our gram-positives, but they also cover our gram-negative organisms. We broadened our spectrum. So our aminopenicillins broadened our coverage with penicillin. Now we have the ability to fight gram-negative as well as the gram-positives. So what are some of the high-yield indications for the aminopenicillins? They're going to be acute otitis media, strep pharyngitis, and listeria. So those are the three big ones I'd know for your aminopenicillins. Otitis media, strep, listeria. There's some other less high-yield indications. Remember, amoxicillin is one of the meds that we use to treat H. pylori. Remember, in triple therapy, you have clarithromycin, amoxicillin, PPI. It's another option in Lyme disease. Doxy is generally preferred, though, unless the patient's pregnant or a young child. Some caveats I'll discuss when we get to the tetracyclines. But generally, when you're thinking of your aminopenicillins, be thinking otitis media, strep, and listeria. Those are the ones you need to know. All right, so this subclass of penicillin worked well. We picked up some gram-negative coverage in addition to our gram-positives. But the problem was this class was susceptible to beta-lactamase. So beta-lactamase are enzymes produced by bacteria that break open the beta-lactam ring, inactivating the beta-lactam antibiotic. So what we had to do was we had to find a way to take these antibiotics and help them resist that beta-lactamase. So what we did was we came up with the beta-lactamase inhibitor penicillin. So we take the same antibiotics we just went over, amoxicillin, ampicillin, and we added a beta-lactamase inhibitor, which prevents the beta-lactamase from eating the beta-lactam ring and destroying the antibiotic. You can think of it as a shield for the antibiotic, and that's exactly what I used to think of. So I used to think of you have amoxicillin here, same amoxicillin antibiotic, but you just gave him a shield. You gave him clavulanate, which is his shield to protect against those beta-lactamase, so it doesn't break it down. So whether it's amoxicillin or ampicillin, we just give them a shield. So beta-lactamase. So the shield for amoxicillin is the clavulanate or clavulanic acid, and that combo is known as augmentin. And then with ampicillin, we gave it sulbactam. Sulbactam is its shield, and then we have unicin, which is known as, so amoxicillin, clavulanate, that's augmentin, and then ampicillin, sulbactam, unicin. We're taking the same antibiotics we just talked about in the aminopenicillins, but we gave them a shield to help them broaden their coverage and help them protect against some other things. So they cover gram-positive, gram-negative like we went over, but the key here is they picked up really good anaerobic coverage with these beta-lactamase inhibitors, which allowed them to fight some bugs we haven't really talked about before. So what are the high-yield indications for these beta-lactamase inhibitors, penicillins? So we now have coverage for our acute sinusitis. Amoxiclav is going to be your first line for a sinusitis. Animal bites as well as human bites. Amoxiclav is first line. And then aspiration pneumonia. So first line for aspiration pneumonia, because if you remember, aspiration pneumonia most commonly caused by anaerobes, which I talked about we picked up coverage for, and that's why this class is a good choice. Also be aware amoxiclav can be used as first line for acute otitis media as an alternative to amoxicillin in some specific cases. In adults, a few other things, but I wouldn't worry about that too much for this. Those are the main ones that I remember hearing about, and those are the ones that I would remember for this class. All right, so we have all of these different types of penicillin. We've covered a bunch of different things, a wide variety of organisms. But what about Pseudomonas? We haven't talked about Pseudomonas. None of these have really covered Pseudomonas yet. So where do our anti-Pseudomonal penicillins come in? Well, that's with our anti-Pseudomonal penicillins. So these are broad spectrum antibiotics. You're not going to use this on your average patient. The key here is their coverage of Pseudomonas. And what we have is we have Pip-Tazo, Piperacillin, Tazobactam, and Ticarcillin, Clavulanate. So they cover most organisms. They're going to cover your gram-negatives. They're going to cover your gram-positives. They're going to cover Pseudomonas, anaerobes, which is really, Pseudomonas is really the key, the reason they're used most commonly. It's really easier to focus on what they don't cover because they cover almost everything else. They're not going to cover MRSA, and they're not going to cover your atypicals like mycoplasma. They're just really good at everything else, though. There's not really a specific high yield indication, I would say, to know for these. Just be aware, particularly when Pseudomonas is suspected, like in hospital-acquired pneumonia, this class is going to be utilized, particularly with Pip/Tazo, because that has the best coverage of Pseudomonas. They also can be used in really severe soft tissue infections, intra-abdominal infections. So those are your anti-pseudomonal penicillins. Remember Pip/Tazo, because that's the one you'll hear most commonly about, which is also known as Zosyn. You'll hear about that when you're on your hospital rotations and things like that. It's more for your really sick patients. Again, it's not going to be used in your everyday run-of-the-mill infection. All right, so let's go over some general adverse drug reactions for the penicillin class as a whole. There's a few things I think you should know about. So first, hypersensitivity reactions. Of all the drug classes we're going to talk about, penicillin is the class most associated with hypersensitivity reactions. Another one is your hematologic reaction, so whether it's thrombocytopenia, neutropenia, immune-mediated hemolytic anemia, it's all possible in the beta-lactam class in general, but particularly in the penicillin antibiotics. And then finally, GI. So this is really non-specific because all of the antibiotic classes can cause GI problems. But in the penicillin class, there's a couple main culprits to look out for. That's ampicillin and amoxicillin. They're well known for causing diarrhea. But particularly augmentin, which remember is the combo of amoxicillin and clavulanate, this penicillin has the highest incidence of diarrhea of all the penicillins. And I would advise you in real life when you're prescribing, if you can give somebody amoxicillin rather than augmentin, the amoxiclav combo, please do, because augmentin just has a really high incidence of diarrhea. So it's not great for your patients if you don't have to give it. So just keep that in mind. Again, GI is really non-specific for antibiotics, but for penicillins, remember your amoxicillin, ampicillin, specifically augmentin, that combo. All right, so that's penicillins. Those are the main things I think you should know. Let's move on to a class that seems to give a lot of people problems, and it's the cephalosporins. It always seems to come up, and there's a few things that you really need to know for it. So this is where some of your mnemonics come in that I created that I think are going to help you. So before we start with the cephalosporins, I wanted to review an easy way to remember the coverage for cephalosporins. So particularly your gram-negative versus gram-positive coverage. So as the cephalosporin generations go on from first to second to third to fourth generation, they lose gram-positive coverage and they gain gram-negative coverage. Now, it's not 100% accurate in every case. There's some exceptions, but a general rule with the cephalosporins is as the generations go on from first to fourth, they lose gram-positive and they gain gram-negative. So in general, first generation is really good at covering gram-positive, not so good at gram-negative, and fourth generation has really good gram-negative, but not so good gram-positive. Fifth generation doesn't really follow these rules, is really good at both gram-positive and gram-negative, particularly really great gram-positive. But generally, first to fourth, you're going to see decreasing gram-positive and increasing gram-negative. So as the cephalosporins, like I wrote out here, go on from first to second to third to fourth, they lose gram-positive and gain gram-negative. That seems so simple, and it seems like, oh, I'll definitely remember that on the exam, but you have so many things to remember. And I remember even like having an exam question and being like, wait, is the first better at gram-negative or gram-positive? So I have a really simple way to remember that. So all you think of is the podium. You know, with the Olympics, you have your first place, second place, third place, etc. This helps you remember. When you get in first place on the podium, you are super positive, you're super happy, super positive, and that's your first generation. So that helps you remember first place, first generation cephalosporins, super positive, covers positives really well. As the generations go on, as the places go on, when you're like in second place, you're still pretty positive, but you're a little bit more negative. And then third place, you're pretty negative at this point. You're not very positive at all. So that helped me remember. When you think about that, you're like, wait, is first better at positive or negative? Just think about it. When you're in first place, are you positive or you're negative? You're super positive. When you're all the way in third place, you're pretty negative at that point. And that's because your third gens cover negative much better and you're much less positive. So hopefully that helps you remember. It helped me. Let's move on to our first generation and get started. So first generation cephalosporins, we have Cephalexin, also known as Keflex is the brand name. That's going to be your PO version. And then we have Cefazolin, that's ANCEF, and that's going to be your IV version of the first gens. So what do you need to know for these? As I said before, these are going to have really great gram-positive coverage. Staph, strep, it's going to cover really well. So your skin infections, really. It does have some mild gram-negative coverage, but it's mainly gram negative like for E. coli, Proteus, Klebsiella, but the main use for your first gens, what they do best is gram positive organisms. Remember, you're in first place on the podium, you're super positive, you got first place. Now, high yield indications, there's two that you need to know. Skin infections and surgical prophylaxis. So skin infections, MSSA, methicillin sensitive staph aureus. So all your skin infections involving staph, folliculitis, paronychia, etc., MSSA, be thinking of your first gens, particularly cephalexin, which is your PO med. And then surgical prophylaxis, that's going to be cefazolin, which is known as ANSEF. So when you do your surgical rotations, you're going to hear this all the time. Before every surgery, they're going to say 2 grams of ANSEF on board. It's basically the most commonly used antibiotic for surgical prophylaxis, and I feel like that's really the only thing you should memorize is these two things. Those are the main things for your first gens. All right, so let's move on to our second generation. That is going to be, the main ones are going to be cefoxitin, cefuroxime, cefaclor, and cefotetan. So how the heck do you remember that? I mean, there's so many different cephalosporins. So the way that I used to remember that is I thought of this. I thought of your second generations. I thought of 2 furry fox drinking tea on the floor. So you have 2 of these foxes. That helps you remember your second generation cephalosporin. Furry, they're furry. That helps you remember your cefuroxime. Fox, cefoxitin. Drinking tea, cefotetan. On the floor, cefaclor, which F-L-O-R. So you say cefaclor, it kind of sounds like floor. So 2 furry fox drinking tea on the floor. 2 second generation furry cefuroxime. Fox, cefoxitin, drinking tea, cefotetan on the floor. They're drinking tea on the floor, and that's cefaclor. So that helps me remember the second generation cephalosporins. All right, what are they good at? So they have gram positive coverage, but weaker compared to first gen, and they have gram negative coverage, but broader compared to the first generations. And they pick up some coverage for Enterobacter, Neisseria, and the gram negative, but then they have anaerobic coverage. So this is really important. So first gens had better gram positive coverage. Your third gens, as I'll go over next, have better gram negative coverage. So the second gens are kind of like the forgotten middle child, but the key for the second gens is their anaerobic coverage with cefoxitin and cefotetan. This is particularly good for your pelvic infections, some of your intra-abdominal infections, and this is what you're normally going to see them tested on. That's really what I'd focus on, because like I said, they're not great as the first gens as gram positive. They're not as good as the third gens for gram negatives. So they're kind of in between, but what they have unique about them is their anaerobic coverage, and that's what you're going to see come up. So they do have some indications for covering UTIs, respiratory infections, Lyme disease, second line to doxy. But for the sake of the exam, what you need to focus on is your intra-abdominal and your pelvic infections involving anaerobes like Bacteroides. That's what you're going to see when you see these covered. You're going to see your intra-abdominal and your pelvic infections. Cefotetan and cefoxitin are really good for PID, for pelvic inflammatory disease. There is some resistance being seen with cefotetan for B. fragilis. So for your intra-abdominal infections might not be the best choice anymore, but overall they're really good for PID. And in general, this is what you're going to see them tested on, your intra-abdominal, your pelvic infection. So that's what I would know for your second generation. All right, let's move on to our third generation cephalosporins. That's going to be ceftriaxone, cefotaxime, and ceftazidime. There are some others in this class like cefpodoxime, but really these are the 3 that ever seem to come up. These are the ones that I would focus on. So how do you remember these? How do you remember those 3 for their third generation? I remember this sentence. You can try ceftriaxone, and also try helps you remember third generation. Taxing, cefotaxime, me, but you won't get a dime, ceftazidime. So you can try ceftriaxone, try third gen, taxing me, cefotaxime, but you won't get a dime, ceftazidime. That helped me remember the main ones you need to know for this class. They have excellent gram negative coverage. That's the main thing, including Pseudomonas with ceftazidime. Gram positive coverage overall is decreased. Some antibiotics in this class, like ceftazidime, have virtually no gram positive coverage at all. Your third gen is mainly about your gram negatives and Pseudomonas, but only with ceftazidime. That's important. Remember, ceftazidime has Pseudomonas coverage, and I have another mnemonic for that. So the way that I used to remember that is if you sue me, you won't get a dime. So ceftazidime, only third gen to cover. Sue, Pseudomonas. I know that's not how it's spelled, but that's how it's pronounced. Then helps you remember. If you sue me, you won't get a dime. Ceftazidime, only third gen to cover Pseudomonas. All right, so what are your high yield indications for your third gens? So there's a few things that always seem to come up. Gonococcal infections, ceftriaxone, meningitis. So third generation cephalosporins like cefotaxime, ceftriaxone are the beta-lactams of choice in the empiric treatment of meningitis. Generally, they're going to be combined with other antibiotics, but those will definitely be used. And then community-acquired pneumonia, hospitalized, are you going to use some of your third generations for that? So those are the main things that I think you need to know for your third gen cephalosporins. Let's move into the last two, which are a lot easier. There's not as much to know. So fourth generation, there's only one you have to know, cefepime. Nice and easy. That's the only fourth generation cephalosporin. Now, what does your cefepime cover? What does your fourth generation cover? It's basically gram negative. Main thing here to know is Pseudomonas. Very limited gram positive coverage. It does have some coverage of MSSA, but Pseudomonas, that's the key to remember. Like I said, you get some gram negative, some gram positive, mainly for staph, but specifically remember Pseudomonas. That's the main thing you need to know for your fourth gen. So there's not a lot to know about cefepime. Basically that it's a fourth generation cephalosporin, and then it has good coverage against Pseudomonas. That's all I'd remember, but how do you remember that? So the way that you remember that is cefepime. Instead of remembering cefepime, remember cephorpime. So cephorpime helps you remember it's a fourth generation cephalosporin. And then cephorpime helps you remember Pseudomonas, which has 4 syllables. So that's all I remember for cefepime. So instead of cefepime, remember cephorpime, fourth generation cephalosporin, covers Pseudomonas, 4 syllables. And that's it. That's your fourth generation cephalosporin. Let's move on to fifth generation, which is also very simple because you basically just have ceftaroline. It's another easy one. That's really the only one that you need to know because that's the only fifth generation we have in the US. Outside of the US, there's another fifth gen cephalosporin called ceftobiprole. Don't worry about that one. Ceftaroline is really all you need to know about. And the only thing you really need to know about it is that it covers MRSA. It's the only cephalosporin that does. That's the primary use for this drug, MRSA. That's really it. So how do you remember that? Okay, so ceftaroline, instead of remembering ceftaroline, add an S here. You see ceftaroline, just add an S in there. You have cefstaroline. So what do you need to know about cefstaroline? So cefstaroline is all about the stars. So remember this. So ceftaroline, a star has 5 sides. 1, 2, 3, 4, 5. That helps you remember this is your fifth generation cephalosporin. What else do you need to know about the stars? Well, when you look out into the stars, what's the closest planet nearby that you can see out in the stars? It's Mars. Well, what is Mars rearranged? MRSA. When you spell MRSA, M-R-S-A, that's just Mars rearranged. You put this A right here, you have Mars. So remember ceftaroline, just think of cefstaroline, the stars, and you think a star has 5 sides, fifth generation cephalosporin. You think when you look out into the stars, you see Mars. What is Mars? MRSA rearranged. This is the only cephalosporin that has MRSA coverage. So that's it. That's all you need to know for your fifth generation cephalosporins. All right, let's keep moving along. So Monobactam. Monobactam is an easy one. There's only one medication in this this class, and that says Trionam. What does Trionam do? It covers gram negatives, including Pseudomonas. That's basically all it does. It covers your gram negative aerobes. It has no gram positive coverage, so obviously doesn't cover MRSA, doesn't cover your anaerobes. It's just gram negatives. Pseudomonas is the main thing you need to know here. The problem is with Trionam is that there's a lot of resistance in most institutions against Pseudomonas coverage. So normally you need to utilize empiric double coverage with your Trionam, with your Monobactam. There's really only one thing you need to know about Trionam, and that is that it has no cross-reactivity with other beta-lactam antibiotics. You can give if they have a penicillin or a cephalosporin allergy. That's the main thing. This is really the only thing that this drug, as far as exams, exists for. If you see Trionam, they're just asking you a question that says a patient has a penicillin allergy, and which one of these are you going to give? And they're going to list a bunch of penicillins and cephalosporins, and Trionam is going to be on there. That's why that question is there. It literally exists for exam purposes just for that. So the only FYI I'll give you with that, which you probably don't need to remember for the exam because I don't think they're going to be that evil, but so it's safe in penicillin allergy, it's safe in cephalosporin allergy, but there is an exception, ceftazidime, because they share a similar side chain Like I said, I don't think they're going to be cruel and do this to you in a question, but it's just important to know that real life aztreonam you can give with a cephalosporin or penicillin allergy, except ceftazidime, because it does have a similar side chain. And as we know, ceftazidime is a third generation cephalosporin. How do you know that? Because remember, if you try taxing me, you won't get a dime. So try third generation, dime, ceftazidime. All right. Okay. The other thing to know about it, I would say not as important as that, as the cross-reactivity, but it can be used in patients with renal insufficiency. It doesn't cause any renal toxicity, so that's another side thing to know about it. All right, so that's your monobactams. Let's move on to our carbapenems and then wrap up our beta-lactams. So carbapenem, what's included in this class? Imipenem, celastine, meropenem, and ertapenem. So just an FYI, imipenem, you see it's the only one that has an additional medication. That's because it can never be administered alone. It always gets combined with celastine. The reason is because if you give it by itself, it actually gets inactivated by the proximal renal tubules, and it can lead to necrosis of the proximal tubule. So you'll always see this carbapenem combined with celastine. So that's just a little thing to know about it. So what do carbapenems cover? Almost everything. They're extremely broad spectrum antibiotics. So they're going to cover your gram-positive, they're going to cover your gram-negatives, including your ESBL organisms, which is your extended spectrum beta-lactamases. They're going to cover Pseudomonas. They're going to cover your anaerobes. They're really going to cover almost everything. It's easier just to remember what they don't cover, and that's really just MRSA and your atypicals. Otherwise, you can pretty much use these for anything else, and that's why in practice, you won't. Because really broad spectrum drugs like these should rarely be used because they breed resistance. They're basically just reserved for severe infections where you don't know what the bug is yet. The person's on their way out and you just kind of have to throw everything at them. Now, I put Pseudomonas up there and I put a little asterisk. That's because there is one exception to that. Ertapenem is the only drug in this class that does not cover Pseudomonas. So the way that you remember that, if they give you a question and they say patient has blah, blah, blah infection with Pseudomonas, which one of these are you going to use? And they give you a bunch of carbapenems, or they say which is the only one that you wouldn't want to use. If you see ertapenem, that's the only one that does not cover Pseudomonas. The way that I used to remember that, it's the only drug in the class that has an E. So I just remember that E stood for exception to the rule. That rule being all carbapenems cover Pseudomonas, because it does not. So that is what you need to remember. Now, the what I'm going to say as far as like the ADRs, the adverse drug reactions, is there's really only one thing that I would remember, and that's that these drugs can lower the seizure threshold. This is particularly important with your imipenem, and they can cause CNS toxicities. Outside of that, I wouldn't really remember too much else about them. Just remember they're super broad spectrum antibiotics, and remember that exception to that rule with ertapenem. All right, so that's the end of the beta-lactams that covered penicillin, cephalosporins, carbapenems, monobactams. So those are some of your big heavy hitters for your exams. You'll get a lot of questions based off of those, but let's keep on moving for some other important ones. Let's move on to our aminoglycosides. So that's going to include gentamicin, tobramycin, amikacin, neomycin, and streptomycin. So what do these cover? Basically just gram-negatives, including Pseudomonas. They have little to no gram-positive coverage, no anaerobic coverage. They're basically just gram-negative. Now, there's not really any high-yield indications I'd memorize for your aminoglycosides. There's very few instances where you'd use monotherapies with systemic aminoglycosides. There's really just two, and it's tularemia and plague. So those aren't exactly high-yield diseases. You also can use it for synergistic effect with other drugs in endocarditis, but overall, the highest yield thing about aminoglycosides isn't their indications, it's their ADRs. I remember getting asked about clinical rotations about this on exam questions. It's the most important thing I would remember about your aminoglycosides, and there's two things that you need to know. They can be ototoxic. So aminoglycoside-induced ototoxicity can result in either vestibular or cochlear damage, and they can be nephrotoxic. So 10 to 20% of patients can experience some degree of nephrotoxicity. In most cases, though, aminoglycoside nephrotoxicity is reversible, which is good. All right, so with your aminoglycosides, there's really two things that you need to know. You need to know that they basically just cover gram-negatives, including Pseudomonas, and you need to know those ADRs. They're really important. So how do you remember that? Well, all medications with aminoglycoside end in CIN, tobramycin, amikacin, neomycin, they all end in CIN. I know there's other drugs in other classes that also end in CIN, but you're just going to kind of have to remember this for the mnemonic. So they all end in CIN. What does CIN stand for? So CIN in aminoglycosides, you need to remember, is that coverage includes negatives, because remember they only include negatives, gram negatives, and then CIN stands for crushes incus and nephrons. So incus, of course, one of your auditory ossicles that helps you remember, it gets crushed, leading to ototoxicity, and nephrons, of course, your functional unit of the kidney, helps you remember nephrotoxicity. So aminoglycosides, just remember they all end in CIN. CIN stands for coverage includes negatives because they only really cover gram negatives, and then that also stands for crushes incus and nephrons. That helps you remember the ototoxicity and the nephrotoxicity, because that's really all you need to know about your aminoglycosides. All right, moving right along to our tetracyclines. So tetracyclines is going to include doxycycline, tetracycline, minocycline. So there's a few different meds in the tetracycline class, but it doesn't matter because this is the doxycycline show. Most things that you're going to need to know about tetracyclines is going to be about doxy. So make that your focus. Tetracyclines, basically just remember doxycycline. What do they cover? A lot. So they cover your gram negatives, they cover your gram positives, including MRSA. They cover your atypicals, and then they cover your weird stuff. So weird stuff, what's that? Well, anytime you have some odd organism, some unusual pathogen, you should be thinking about using a tetracycline. So Vibrio, Brucella, Q fever, anthrax, Lyme disease, they're all covered by tetracyclines, usually doxy, of course. What are some of your high yield indications? So again, this is just going to be focused on doxycycline. There's not a lot of high yield indications for minocycline and tetracycline. Minocycline is really just used for acne. So high yield indications are all going to be about doxy. So what does doxy cover? Covers three things really well. These are your first line indications. So chlamydia, Rocky Mountain spotted fever, and Lyme disease. So chlamydia. Doxy is now your first line for chlamydia. It used to be azithromycin, but due to superior efficacy with doxy compared to azithro, the guidelines have changed, and now it's going to be doxy 100 milligrams BID 7 days for first line treatment. You may still give azithromycin to some patients, especially your non-compliant patients, because the nice thing about azithromycin is it's a one-time dose. You give them 1 gram of azithro and they're done. But the problem is it doesn't cover it as well as doxy. So really, first line, the right answer choice on a question is going to be doxy. Also covers Rocky Mountain spotted fever. First line, pretty much all patients are going to get doxy for Rocky Mountain spotted fever. Even in young children, just a heads up about Rocky Mountain spotted fever treatment in pregnancy. Chloramphenicol used to be first line for your pregnant patients, but now even that's being replaced by doxy if you look at the updated guidelines. So Rocky Mountain spotted fever, pretty much doxy all the way. Lyme disease. So first line for your non-pregnant adults, your older children with Lyme disease, they're always going to get doxy. Kids under 8, the guidelines are kind of muddy. You're going to be taught that less than 8, you normally give them amoxicillin, over 8 doxy. I'd probably learn it that way for the boards, but the guidelines, again, it's changing. It really depends on the stage of the infection the child has. If it's just cutaneous disease, normally you'll give them amoxicillin. But if there's any signs of neurologic involvement, then you're going to use doxy because it covers it better. And actually, the American Academy of Pediatrics supports the use of doxy for children under 8, as long as it's administered less than 21 days, which it is for Lyme disease. Anyways, I know that made it kind of confusing. Overall, when you see tetracyclines, think particularly doxy. You're going to be covering chlamydia, Rocky Mountain spotted fever, and Lyme disease first line. So how do you remember that? This is the way that you remember that. So I used to remember when you're sitting on a dock by the sea, doxycycline, eating clams and Rocky Mountain oysters with a squeeze of lime. So you're sitting on a dock by the sea, doxycycline, eating clams, helps you remember chlamydia, and Rocky Mountain oysters. Rocky Mountain oysters are not oysters if you want to look that up, but it helps the mnemonic work. That helps you remember Rocky Mountain spotted fever with a squeeze of lime. So that's Lyme disease. So that helps you remember doxy, sitting by a ducks by the sea. It's your first line treatment for chlamydia, you're eating clams, Rocky Mountain spotted fever, you're eating Rocky Mountain oysters, and Lyme disease, and that's your lime squeezed over the top. So that helps you remember all of the high yield indications for your doxycycline. All right, what are the adverse drug reactions that you need to know? There's a few that are pretty high yield here. First one is teeth discoloration and the fact that it can also inhibit bone growth in children. So tetracycline antibiotics have been associated with permanent tooth discoloration in children under 8 years old if used repetitively or for prolonged courses. This does not happen in adults. Tetracyclines also may deposit in the bone and affect growth, and this is why we're cautious about using this class in young children. They also have impaired absorption when taken with certain minerals and acids like aluminum, calcium, iron, magnesium. So certain vitamins or dairy products when taken at the same time as a tetracycline can chelate with the antibiotic and impair its absorption. So just be careful. Make sure you tell your patients about when they're taking this medication to avoid certain supplements and acids, etc. And then finally, photosensitivity. So there's other classes that can cause photosensitivity reactions, but it seems to come up most commonly in questions about tetracyclines. So the effect can range from a red rash to blistering on exposed areas of the sun. So you just want to warn your patients about this as well. All right, so that's our tetracyclines. Let's move on to our fluoroquinolones. So the first thing to know about this class is you're generally going to avoid using it in your run-of-the-mill infection. So if you have like a rhinosinusitis, uncomplicated UTI, the risks outweigh the benefits. So keep that in mind when you're practicing. You're not going to give Cipro for a simple UTI when you can just as easily give nitrofurantoin. So save this for your more complicated infections. So the medications in this class are going to be ciprofloxacin, levofloxacin, and moxifloxacin. Those are the three that you need to know. Let's start with moxi. So moxifloxacin is what's known as your quote-unquote respiratory fluoroquinolone. It's not an official term, but that's the term that's most commonly used. A lot of people know this one as well as levofloxacin as your respiratory fluoroquinolone. So moxi, in addition to levofloxacin, they're considered respiratory fluoroquinolones, and the reason is because they're both active against your most common respiratory pathogens, including strep pneumo, H. influenza, moraxella. Threw a little accent on there, and that's why we call them unofficially our respiratory fluoroquinolones. Now, moxi in particular has our best gram-positive coverage, also our best anaerobe coverage, also has really good coverage of our atypicals. It's really the only of all of fluoroquinolones that has decent anaerobic coverage, and because of this, it can be used for some intra-abdominal infections, although it's somewhat limited due to some resistance among the Bacteroides species, so it's not the best option. It can also be used as an alternative to ampicillin, sulbactam, and aspiration pneumonia. So be aware that moxi, unlike the other fluoroquinolones, actually has some anaerobic coverage, so you may see that come up in a question. I'd say of the three fluoroquinolones, this is probably going to be the one you're asked about least. Most questions from my experience come about Cipro and levofloxacin. And again, if you're asked anything about moxi, it's probably going to be related to its coverage of anaerobes. All right, so levofloxacin. This is another respiratory fluoroquinolone, as we just went over with moxi, the same reasons. The big difference between moxi and levofloxacin, though, is that levofloxacin also has some activity in the urinary tract. It can be used as an alternative to ciprofloxacin in some cases for pyelonephritis, your complicated UTIs, where moxi cannot. Moxi has virtually no urine activity. It has good gram-positive coverage. It has good coverage of atypicals. So levofloxacin, as far as coverage, it's kind of in the middle here. Moxi has the best gram-negative. Cipro's got the best gram. Moxi has the best gram-positive. Cipro has the best gram-negative. Levofloxacin is kind of hanging somewhere out in the middle, but it does have really good strep pneumo coverage, better than moxi actually, which is why it can be used as monotherapy in community-acquired pneumonia. Although we try not to use it for pneumonia to prevent fluoroquinolone resistance among the respiratory pathogens. And like I went over before, levofloxacin also does have similar coverage as seen in ciprofloxacin for your UTIs, complicated UTIs, etc. So they can be used interchangeably. So that's levofloxacin. Let's move on to Cipro. So the main thing to know about Cipro is that it is not a respiratory fluoroquinolone. It is a urinary fluoroquinolone. So it's first line for pyelonephritis, your complicated UTIs. Ciprofloxacin is the only fluoroquinolone in it that has a P in it. So as soon as I see Cipro with a P in it that the other ones don't have, it always makes me think of your pee-pee stuff. So pyelonephritis, UTIs, prostatitis in your older males. A lot of people think the reason we don't use Cipro for some of the respiratory tract infections like pneumonia is because it doesn't penetrate the lungs, but that's actually not the case. So Cipro has lesser activity against your gram-positive organisms, in particular strep pneumo. And that's the reason why we don't use it for most respiratory infections and reserve that for moxi and levofloxacin, which have great gram-positive coverage. So it's not that Cipro doesn't penetrate the lungs, it's just that it doesn't cover our respiratory organisms. So overall, the main thing to know about Cipro is it has your best gram-negative coverage of the fluoroquinolones, including Pseudomonas, the best Pseudomonas coverage. So remember, for your fluoroquinolones, Moxie is going to have your best gram-positive, and it's also the only one with really good anaerobic coverage. Cipro has your best gram-negative coverage, including Pseudomonas, and then levofloxacin is kind of in the middle, but it has really good strep pneumo coverage. So what are your high-yield indications for your fluoroquinolones? That's going to be pyelonephritis with Cipro and levofloxacin. Complicated UTI, Cipro and levofloxacin. Uncomplicated, of course, you're sticking to Bactrim or nitrofurantoin, which is Macrolide. Prostatitis, ciprofloxacin, levofloxacin can be used as empiric therapy. In your older patients, younger patients, of course, you're covering more for chlamydia and gonorrhea. But prostatitis in your older patients, you can use Cipro and levofloxacin. And then community-acquired pneumonia, so levofloxacin, moxifloxacin, these can be used as monotherapy, but generally they're going to be reserved for your patients with comorbidities, older patients, etc. All right, ADRs. There are some high-yield one with the fluoroquinolones. So they have a bunch of adverse drug reactions that are possible, GI, of course, being the most common, as in most antibiotics, but I'm going to focus on the ones that always seem to come up in the exam questions, the more unique ones, and really there's three. So the first really big one is your QT prolongation. So fluoroquinolones can prolong the QT interval, potentially leading to torsades. So we avoid this class in patients taking QT prolonging drugs or patients with long QT syndromes or any other risk factors for arrhythmia. So that's the first big one for fluoroquinolones, QT prolongation. Second one is tendinopathy or tendon rupture. So fluoroquinolones can cause tendinopathy and tendon rupture. The most common site is going to be the Achilles tendon. So always be careful to tell your patients, avoid vigorous exercise while on the medication, and have them alert you of any signs of tendinopathy, pain, swelling, etc. And then finally, an interesting one, but one that I actually had on an exam question, is that they can precipitate myasthenic crises. So fluoroquinolones actually have a black box warning for use in patients with myasthenia gravis because they can cause neuromuscular blocking activity, which can precipitate a myasthenic crisis. So remember that for real life and your exam questions. It's an important thing to know. All right, so that's your fluoroquinolones. Let's move on to our macrolides. So that's going to be azithromycin, clarithromycin, erythromycin. So these are really good, well-rounded drugs. They cover a lot of different things. They cover your gram-negatives, your gram-positives, your atypicals. Class has pretty broad spectrum of activity, particularly with your atypicals. Azithromycin is going to have your best atypical coverage. That's going to be your drug, of course, drug of choice for your atypicals. Now let's go over some of your high-yield indications. First one is going to be chlamydia with an asterisk because I talked about this before. This used to be your first line for treatment of chlamydia, but new evidence, like I said, is showing that microbial efficacy of doxy is superior. So most guidelines are going to say doxy is going to be your first line, but azithromycin is still a good second line option, and you still need to be aware of it. Another high yield indication is going to be your MAC, so your Mycobacterium avium complex, azithromycin, clarithromycin. So macrolides are your cornerstone of antimicrobial therapy for MAC treatment and prophylaxis in your HIV patients with MAC. It's usually going to be combined with rifampin or ethambutol, but remember, macrolides are always going to be used in patients with MAC. So just remember, when you're treating MAC, use a macrolide. So macrolides treating MAC. It helps you remember that. Okay. Community-acquired pneumonia. So azithromycin, clarithromycin, both your typical organisms like strep pneumo as well as your atypicals like Mycoplasma pneumoniae, macrolides are going to be your first line options, particularly azithro for your atypicals like your Mycoplasma. Gastroparesis is another one. This is really just with particularly with erythromycin. So erythromycin increases gastric motility, and it can be used as another option in addition to metoclopramide, which is normally your first line agent, but be aware of erythromycin as well. And then another one that you may see come up is your COPD bacterial exacerbations. So in chronic bronchitis, with your bacterial exacerbations, macrolides will commonly be used as your first line to treat. And in selected patients with severe COPD with frequent exacerbations, macrolides can actually be used prophylactically to prevent exacerbations. Now your ADRs, there's a few ones that you need to know. Again, this is going to be another one that can cause QT prolongation. So all macrolides have been associated with QT interval prolongation. So before giving one of these meds, make sure that the patient's not at risk for torsades, taking any other meds that can prolong the QT interval. They do have some pretty prominent GI side effects, and I know I've said this is non-specific, but with your macrolides, of course, they can have their run-of-the-mill diarrhea, abdominal pain, but they also have the possibility of hepatotoxicity with azithro and even acute cholestatic hepatitis with erythromycin, so be aware of those as well. And then your cytochrome P450 inhibition. So you have to look out for drug interactions with other drugs they may be taking, like statins, warfarin, digoxin. This can change the absorption of these medications. All right, so we are going to move on to our last class that I feel is important for you to know, and that's Vanco. So vancomycin. Vancomycin covers your gram-positive MRSA. That's what you really need to know about vancomycin, MRSA. It's really not used for a lot as far as your high-yield indications. There's really just two things that you need to know. MRSA, of course, like I said, that's a big one. Vanco and MRSA are synonymous. As soon as you hear Vanco, right away you should be thinking MRSA. The other high-yield indication is for C. diff. So Vanco is almost always given intravenously. We don't usually give Vanco PO because it has very poor GI absorption. But the exception is when we're treating C. diff. We don't need Vanco to get absorbed systemically to treat C. diff. We need it to just stay in the GI tract and actually not get absorbed. And that's why PO Vanco, because of its poor GI absorption, is actually an asset when treating C. diff. So with Vanco, it's really the only time you're going to give Vanco PO. It's to treat C. diff. Otherwise, MRSA, you're going to give it IV. So those are really the two main high-yield indications. I really wouldn't worry about anything else. See vancomycin, be thinking either MRSA or C. diff. This does have some high-yield ADRs, though, some high-yield adverse drug reactions. First one is going to be red man syndrome. So it's not really called red man syndrome anymore. It's called vancomycin-infused infusion reaction associated with rash. So let's just keep calling it red man syndrome. So this is something unique with Vanco. And like most unique things, it's often tested on. Basically, if you infuse Vanco too quickly, you get this confluent or blotchy rash that covers the trunk, the extremities, the head, the neck, and you avoid this just by infusing it slowly. So that's red man syndrome. It can be caused by Vanco infused too quickly. The other one is ototoxicity. So this is more common in your older patients, generally considered to be reversible in most cases. And then nephrotoxicity is also possible. So Vanco can be nephrotoxic, leading to acute kidney injury. It's more common when it's co-administered with other nephrotoxic agents like loop diuretics, IV contrast dye, amphotericin B, etc. So Vanco has a few high-yield ADRs and it has a couple high-yield indications. So how do you remember them on the exam in addition to the other 10,000 things you need to know about antibiotics? Well, the way that you remember that is as soon as you think of vancomycin, I want you to think of a pimped out van with chrome rims. So chrome spelled C-R-O-M. So pimped out van with chrome rims as soon as you see vancomycin. So you think of this van here, vancomycin, with these pimped out rims, these chrome rims. So pimped out vancomycin with chrome CROM rims. And chrome stands for C. diff. That is one of your first indications for this medication. Of course, that's going to be PO. The R is going to stand for red man syndrome and renal toxicity, your nephrotoxicity. The O in chrome stands for ototoxicity, and then the M stands for MRSA. So if you remember, as soon as you see vancomycin, think of a van with chrome pimped out rims, and that helps you remember C. diff, red man syndrome, renal toxicity, ototoxicity, and MRSA. And you can remember the main things that you need to know about vancomycin. All right, let's wrap this up with 5 quick high-yield questions, see what you remember. So first one, a patient with a penicillin allergy can safely be given which class or medication of beta-lactam antibiotics with no risk of cross-reactivity? So that's going to be as Trianam, your Monobactam class. So beta-lactam that has no cross-reactivity with penicillin or cephalosporins. The exception, of course, remember that ceftazidime that we discussed earlier. Question 2. Patient being treated for MRSA with IV antibiotics begins to develop a red rash across his head, neck, thorax, and extremities as the IV antibiotic is being administered. Which antibiotic is this patient likely receiving? Hopefully remember that because we just went over that. It's going to be vancomycin. So we're treating MRSA. There's really only a number of meds to begin with for treatment of MRSA. Then we see he's developing a rash as the IV antibiotic is administered, which we know can be caused by vancomycin. If the medication is administered too quickly, they may develop that red man syndrome, that confluent or blotchy rash spread throughout the body. Question 3, which is the only medication in the Carbapenem class that does not cover Pseudomonas? So that is going to be ertapenem. Remember, it's the only carbapenem that starts with an E. That's because it's your exception to the rule that all carbapenems cover Pseudomonas, because ertapenem does not. Question 4, which medication is the first line for chlamydia, Rocky Mountain spotted fever, and Lyme disease? That is going to be doxycycline. So don't forget, sitting on a dock by the sea, doxycycline, eating clams, chlamydia, Rocky Mountain oysters, Rocky Mountain spotted fever, with a squeeze of Lyme disease. All right, question 5, last one. Which 5th generation cephalosporin has coverage against MRSA? So that is going to be ceftaroline. Remember, your ceftaroline, star has 5 sides, 5th generation. What's up in the stars? Mars, which is just the letters in MRSA rearranged. All right, so that is antibiotics. I hope that was helpful, and please let me know if it is, or if there's any suggestions or anything you want me to cover coming up in the next few weeks. I'm probably going to be starting neurology pretty soon. Thank you, as always, for your support. I really do appreciate it. And good luck on your PANCE, your PANRE, EORs, and good luck in PA school.